in internet, which can usually publish high quality medical information. There are sites of electronic British Medical Journal, Canadian Task Force of Preventive Healthcare, National Guideline Clearinghouse, Free Medical Journal site, and others. For preparation of very useful instruments for any practical doctor, such as systematic reviews, clinical practice guidelines, recommendation, critically analyze the actual material of clinical, experimental, and statistical research. On 6 years or 1 year, you will perform new practice, training practice. It calls scientific work or research work. During this practice, you will analyze also information from clinical, experimental, and even statistical reports for different problems. And you will conclude, you will present any conclusions from this analysis, critical analysis. It will help in your future practical work for preparation of any scientific reports about your personal outcomes or personal results and achievements of your future practice work. What does mean systematic review? We should understand this term. It is a generalization of primary data on clearly formulated problem, reproducible standard methods. It's used in medicine to evaluate and compare the therapeutic and side effects of treatment and the decision to the individual, group, or popular-based method of treatment. For example, systematic review of antibiotic therapy, systematic review about arterial hypertension management in different countries, and others. A next form of presentation, clinical studies results, is meta-analysis. By simple words, it is summation of the results, several studies on the same topic. Application of ACE inhibitors for hypertensive patients, or any diuretics for patients with chronic heart failure, and other groups of drugs or diagnostic methods. Some diagnostic methods, MRI or CT scan for detection, for example, COVID changes in lungs. Dr. Ebbe said that meta-analysis as strategy is particularly suitable in cases where the individual research results are inconsistent with each other. Then the scale of the individual studies is too small, and the organization of large-scale research is too expensive. In this case, we can apply the results of meta-analysis. We can perform these procedure for detection of most optimal decision. By other words, meta-analysis, the scientific discipline that applies the protocol for critical assessment and uses statistical methods to combine the results of previous research. It represents the quantitative findings of a complete picture of therapeutic effect. As a rule, the total score and the confidence interval variations. Thanks to meta-analysis, increased use to clarify the differences between the studies, including analysis of systematic errors in individual studies. Also, we can explain the inconsistency of results, as well as for promotion of alternative hypotheses. And also we can apply it for planning future research. This procedure of meta-analysis. Now I want to specify for you main types of experimental studies. Clinical trials may be control, when we will compare products or procedures with other medications or other procedures, treatments or treatment therapeutical technologies. These trials are more common and probability of detecting difference in treatment longer in these trials. In uncontrolled trials, experience with the drug or procedure, but without comparison with other treatment options. These trials less common and less certain, and probability of procedures for comparing more than comparison drugs. Most important methodological features or characteristics of different types of research you can see in this table. On first place, as most important and most reliable type of trial is randomized control trial, or RCT. This trial describes the process, should include process of randomization or random choice of patient selection to experimental and to control group. Completeness tracking and elimination. This trial includes blinding of patients and even researchers, so-called double-blind research. Placebo control, for example, usually. Other types of research, cross-sectional studies, less reliable, which we use for verification of the case. Cohort studies, usually this study include not more than 200-300 people. As for randomized control trials, this study includes more than 1,000 people, participants. And random or sequential sampling. This trial provides independent blind comparison of study test results with the gold standard we're using for selection of adequate practice, the real patient population. And now we should specify the scale of evidence levels. According to this scale, all results of different clinical trials can be presented, should be presented in clinical guidelines with special indication by special symbols. Symbol A, if we will see symbol A, it means after, of course, after any recommendation, symbol A, it means high quality results or systematic reviews of randomized controlled trials, or RCTs with very large low probability of bias. And the results of this trial can be distributed to the relevant population in other countries, in other cities. Relevant population, and for example, for this year, same year, similar age, or similar age or gender group. A B level of evidence we can get from systematic review of cohort or case control studies, less level of evidence, or high quality cohort or case control study with low risk of bias, or even RCT with low, not high, low risk of bias, and results can be distributed to the relevant population. C level, it's already low level of evidence. This level appropriate corresponds about cohort or case control studies or control trial without randomization. And results of each investigation can be distributed to relevant population. Or RCT with very low or low risk of bias, the result of which can not be directly distributed to the relevant population. And very low evidence, D level, it means no any trials, just case series, or if trial but uncontrolled study, and in some situations it can be expert opinion in concrete field of medicine. Also, one important parameter which we should analyze during reading of any articles or clinical guidelines is endpoints. Endpoints or significant disease outcomes, which we should analyze in the end after completing of concrete stage of clinical trials. These endpoints we can divide on two parts, two big parts, true or hard. Among them, total mortality, for example, from cardiovascular or oncological or infectious disease mortality, from the occurrence of severe complications of cardiovascular disease such as MI and stroke. Else one, serious or true endpoint, identification of few cases of disease with serious prognosis such as social significant diseases such as very widespread diabetes, bronchial asthma, multiple sclerosis, and others. If any recommendation or if any therapeutic or prophylactic strategy can help to decrease, for example, the number of patients hospitalization, this fact we also can analyze, interpret as a true endpoint of application concrete prophylactic or therapeutical technology. Invasive intervention, it's also a necessity in invasive intervention such as stenting process, angiography, and that is also its true endpoint. And last parameter of among true endpoints, now it's obligatory characteristic which investigators should analyze performing any clinical trial is the level of life quality related to health, especially for patients with some new pharmacological approaches or new pharmacological agents application. Second group of endpoints clinical trials is surrogate or false endpoints. This group includes clinical and laboratory parameters which are relatively easy to measure, can predict long-term outcome of therapeutic intervention, but not themselves direct indicators of such an outcome. Example, you can see assessment of some clinical laboratory instrumental parameters, such as normalization of a level of blood pressure, achievement of target blood pressure level for patients with hypertension. It's very variable, not stable characteristic, or temporary lowering cholesterol level by using constant hypolipidemic therapy without antihypertensive and hypolipidemic therapy. These parameters will return to previous pathological level, of course. So we can't interpret these criteria with these changes as reliable and true. What's the real benefits of evaluation and effectiveness of clinical evidence-based medicine recommendation in practice? Due to correct and regular recommendations, 60% of physicians save in time and improve the quality of diagnostics of disease. In 80% of cases, doctors can receive correct answers to specific clinical questions, and of course it can optimize the process of further patients management. The majority of treatment cases in medical practice currently are associated with the purpose of early diagnosis of disease and further correction of detected violations. It's the goal of so-called primary prophylaxis by early correction of risk factors or early forms of, for example, oncological diseases. So screening, it's very popular, relatively cheap and very widespread survey, mass survey of people who do not consider themselves sick. This procedure we are using to detect hidden diseases occurring with the use of technically simple, relatively inexpensive, and non-invasive procedures with high sensitivity. But you can see on the screen the process of very popular now procedure of pulse oximetry. Also, we can see the tube of peak flowmeter for detection of expiratory problem of patient. ACG device and procedure, diagnostic procedure, also screening procedure for big mass of people. Main characteristics, criteria for the correct choice of screening test. It should be high sensitive method, or be able to identify relatively few common diseases. Specificity, it's important characteristic or criteria which allows to minimize the number of false positive detections, pathological changes. It's especially important now, current our reality, then PCR false positive results or false negative results can influence on diagnostics and patient treatment. Especially it was very serious, significant for false negative or false positive results of HIV tests. Among other main criteria of screening tests are relative simplicity of implementation and low cost for mass application. Ideal example, gold standard, so-called ideal screening method is the measurement of blood pressure level, expensive, available, very simple, and digital rectal examination, but both methods can get for us different, very valuable diagnostic information. Else one criteria is a safety study, a safety study, which based on the likelihood of risk of complications during any test, such as, for example, ultrasound examination of fetal disturbances, and acceptability of diagnostic procedure, acceptability for both for patient and for the doctor, acceptability. According to opinion of Russian specialist of evidence-based medicine, his photo you can see on the screen, it's Vasily Vlasov. He said that then deciding of the need for screening studies, specialists of ABM recommend to take into account at least 3 fundamental criteria. First, the severity of disease. For example, if cancer, of course, it's severe. If it's any temporary problem, such as flu, maybe not. No need to organize special study. Benefits of its detection, any disease detection method, choosing our other, and existence of effective follow-up treatment. If we can't treat any serious disease, such as Alzheimer's, effective treatment, or, for example, multiple sclerosis, if no effective methods, then no need to organize screening, especially very expensive. Severity of disease criterion. We should know probable outcome or prognosis of disease, and also possible risk of complications. For example, high risk of coronary events for patients with predisposition, genetic predisposition can be set based on the daily monitoring of ECG, but its inaccessibility may not provide coverage of screening patients with risk factors. For this person, we can recommend as best choice test with dosed physical stress or stress ECG. For them, it will optimal choice. Which disadvantages of screening methods there are? Effect of the label. Then the impact of the research results can negatively influence on the psychological state of the patients. Especially, as I said before, due to false negative results of any trials. For example, also negative results increase negative results or detection, for example, of cancer, can false confirmation of false positive results of cancer confirmation can increase the risk of patients' anxiety or depression, especially then false positive screen test not confirmed by additional test. It was studied that psychological status in group of women with false positive results of the mammogram a few months later showed signs of depression and anxiety or the anxiety disorders in 49% of them, despite on false positive changes. Now I want to show you examples of recommendations for primary prevention of chronic non-infectious disease according to based on ABM medicine trials. In these trials were proved the refusal effectiveness of very high level of evidence, refusal of tobacco smoking, and limitation of the salt to 5 grams per day, or eating 400 grams or more fresh fruits and vegetables daily, physical activity at moderate pace, walking 30 minutes per day, reducing overweight, and limited. As for limiting alcohol consumption, reducing fat intake less than 30% of calories, and drug treatment of smoking, B level, less evidence than others. And this recommendation also, same recommendation you can see for patients for secondary prevention of cardiovascular disease for patients with confirmed cardiovascular pathology such as hypertension and ischemic coronary artery disease. For them, most effective recommendation, highest evidence level, is eating enough amount of fruits, fresh fruits and vegetables, and recommended physical activity. For other recommendation, the value of this recommendation is less. main difficulties in the way of ABM implementation and practice are associated with fact that most practitioners, general practitioners and other specialists, do not possess the principles of critical appraisal of publication. The frightening complexity of mastering these skills. Of course, technologies of ABM requires additional time for this work and effort that can be felt by a doctor or groups of doctors as distraction from the main his or her activity. Distraction. Sometimes unpleasant, sometimes useless distraction. Also, there are many clinical situations for which not enough evidence-based facts on this moment. And as one argument, many doctors don't have enough motivation to change their habits. Which optimal solution or possible solution for this problem is this solution, the involvement of experts, activization of experts who based on the principles of evidence-based medicine, organization them for preparing information products for practitioners in the form of clinical guidelines, systematic reviews, manuals, literary digests on the most important problems of medicine. And I want to remind for you that during that when you will study different nosological form, you have to be oriented, you have to base in study investigation of this topic. You should based on main positions which you will find in clinical guidelines. These recommendations usually they have a very high level of evidence, and so it can be most reliable for achievement of positive therapeutical or diagnostic or prophylactic results for your patients in your future practice. So I wish you to train this skill of critical thinking and be more attentive during the process of reading the new articles and compare new articles with previous work in this field for searching of better way for our patient, better decision. Any questions for me? The lecture is over.
No, sir.
Thank you for your attention. Thank you for group leaders about the list of present students. Next meeting with you 2 weeks later, 25th of February. I will read new lecture for you.